Hi, good afternoon, friends. And I see that there are 3 of you already on the session, and I hope more than others would join because we had 95% who had registered, 95 individuals who had registered, but we have only 4, and I really don't know if 4 of you are already there. Mohit, I'm unmuting you now. Are you there for the webinar today? Mohit Saini. Fair enough. If you can't activate your mobile or activate the audio, then maybe you could speak or put something on the chat and say that yes, you are around. So, Arjun Kaushal, I'm unmuting you. Arjun, are you there? Can you hear me? Well, it's the same story every time when you begin a new seminar or a new webinar with a new teacher, that there will always be these same questions that are you there and can you hear me? That's the bane of technology, because I can't see you and I really don't know if you are already there, if you are listening or you're listening to some music while your computer shows activity. That's why I'm trying to ask individually if you are there. Abhik, I have unmuted you. Can you hear me? And are you still with us or are you somewhere else?
Yes, sir. Yes, sir. I can hear you.
Okay, cool. And so what do you think is the topic for today's seminar?
Sir, APLA, Anti Phospholipid Antibody Syndrome.
वो तो already आपने पढ़ लिया है. That's very good. And let's see who else is around. Manas Varshne, I'm unmuting you. See if you can use your mic and answer if you're around, Manas.
Yes, sir, I'm here, sir.
Cool, Manas. So you're also interested in anti-phospholipid antibody syndrome?
Yes, sir.
Fair enough. So now, as I believe that some of you are already here, 12 attendees are here against the registered participants, 95. Let's begin the webinar for today, and let me also introduce another panelist that we have on the webinar. And I'm glad to introduce to you Dr. Sonal Pruthi, who is an alumnus from UCMS and has more of a godmother status for all UCMS students, and I will invite her to say hi to you, and she would be providing key inputs in the aspects of cardiovascular disease and antiphospholipid syndrome at some point during the seminar. Sonal, the mic is yours.
Hello, everyone. I am just here to listen in.
Cool. Thank you, Sonal. And let's talk more about antiphospholipid antibody syndrome. It's a very short topic. It's not going to be a very long lecture, so I hope that we will be able to finish this session before 1 o'clock as scheduled. And I would be asking questions and interacting with you in between. I would unmute your mic and I would ask you to speak. And hopefully we will be able to get some interactivity going by this mechanism. We tried this and it worked pretty well okay yesterday, and I am sure that you have access to my screen and you are able to see the screen as we go along from here. And we have 30 participants already. Cool, let's go ahead. So what is APLA? It's just a syndrome in which you have antibodies against phospholipid binding plasma proteins. And the most common among these is the beta-2 glycoprotein 1, that's beta-2 GP1. And the other antibodies that you may encounter are those against the cardiolipin or the anti-cardiolipin antibodies, besides the lupus anticoagulants. So good afternoon to those participants who are joining a couple of minutes late and have now entered the seminar. This is the first slide. You haven't really missed anything. We are talking about antiphospholipid antibody syndrome in today's seminar. And the most common antibodies, like I said, is against the beta-2 GP1 protein. So this slide shows the pathogenesis or the pathophysiology behind the antiphospholipid antibody syndrome and what goes on in the background. Among your handouts, I have also given to you a video and a handout or an article which appeared in NEJM. So Ayushi, I'm unmuting you and I want to ask you if you have been able to see the handouts that I had put in the seminar along with the seminar. There is a link to a YouTube video and there is also this article of NEJM which appears in 2018. I had placed these in the handouts associated with the class. Were you able to access them? Ayushi?
Hello?
Yes, Ayushi, we can hear you.
Yes, sir. Sir, I'm not able to see any handouts.
So in the class, when I set up the webinar, it gives me an option that I can give handouts to the participants. And in those handouts, I placed one link for a video and one NEJM article. NEJM is the New England Journal of Medicine, one of the best medical journals. And I placed this article in there, and most of my session for today is going to be from this particular article. So that's what I was trying to ask, if you were able to see this article or get the handout. Ayushi? No.
Yes, sir. Yes, sir, I'm able to access it. Yes, I can access
You
right
are
now.
able to.
Yes.
Abhishek Gautam, I have unmuted you. Have you also been able to access? I'm just taking a feel as we go along so that I know who is able to access, or if there is any problem, then I can resolve it.
Yes, sir.
You are able to access the article?
Yes, sir.
Okay, I will. Thank you, Abhishek. I will also send the links or send you the slides that I'm going to use for this particular presentation, and you can access those also. In addition, there will be the recording of this session, which will be available on the GoToWebinar website. And you can see the recording of this session even after this recording finishes, and if this class finishes, so that those who have not been able to attend the class or are still interested in the class can use it and can see it later. In addition, those who would like to take a recap or see this class again, then that also should be available to them. I also suggest that you take down or save the recording on your laptops, because once you lose access to the website, then this recording goes away and you're not able to access it again. That's the reason I suggest that you do keep it on your laptops handy. In addition, there would be a survey and a poll associated with this class, and I would be thankful if you take that honestly and send me back your responses so that it helps me in improving the classes in further sessions. So this particular slide is indicative of the pathogenesis of antiphospholipid antibody syndromes. It's not a very difficult slide to understand, but the antiphospholipid antibodies are produced by what are the beta cells. They're releasing the antiphospholipid antibodies in this figure, and these then go and attach to the beta-2 GP1 proteins, which will then open up after attachment and get attached to the endothelial cell membrane. Thereafter, what happens is the cells become activated, the inflammatory cells become activated, and there is promotion of coagulation in the vessels. Intravascular coagulation starts happening. And this also, there is interference with the trophoblasts and the residual cells in the placenta, so which leads to fetal losses or in utero losses while the trophoblast is being formed, not in the placenta. I mean, it's in the trophoblastic phase. Further, this leads to inflammation, vasculopathy, thrombosis, and pregnancy complications. Inflammation, you already understand very well. Pregnancy complications, you understand very well. thrombosis, that the blood coagulates, and vasculopathy, that is vasculoplasty, easy to understand and comprehend, not a very rocket science. So the clinical symptoms of antiphospholipid antibodies are dependent on the nature and the profile of antibodies that you have in the body. So like we said, there are three kinds of antibodies: the lupus anticoagulant, the anti-beta-2-GP1 antibodies, and the ACL, or the anti-cardiolipin antibodies. So let me try and engage a pen and let's see what it does. Yes, so these are the three antibodies that we have: the lupus anticoagulant, anti-beta-2-GP1 antibodies, and anti-cardiolipin antibodies. So if you see this figure carefully, you would realize that there is a triangle below which says the clinical significance. And depending upon the kind of antibodies that are present, the clinical significance reduces. If there are lupus anticoagulant antibodies, you have a greater chance of developing symptoms and more severe symptoms. Whereas if you have anti-cardiolipin antibodies, you have a lesser chance of developing symptoms. And the symptoms are largely only two kinds. There is arterial or venous thrombosis, and there is pregnancy morbidity that happens. So what is the spectrum of the clinical features of these APLA syndrome? So we have something that could begin from asymptomatic individuals. Now, what would asymptomatic individuals present with? Why would they be tested? So these are tested when they are tested for some other disease. They are being evaluated and they are tested for an antibody. Or if they are found to have an increased APTT at some point of time in evaluation, if they suffer early miscarriages, or sometimes when they have a false positive VDRL. So they might be tested for different reasons, and then you detect that these antibodies are present and you find they remain asymptomatic. Sometimes you have arterial thrombosis or venous thrombosis. The arterial thrombosis is represented by stroke or TIAs in the patients who are presenting with arterial thrombosis. Venous thrombosis might be represented by deep vein thrombosis occurring in the lower limbs, or pulmonary embolism, which the patients may come with. There would be obstetric complications. Usually there are fetal losses after 10 weeks of pregnancy, and sometimes there would be catastrophic APLA, or catastrophic antiphospholipid antibody syndrome, which involves the multi-organ systems. So I will take a break at this phase, and I would like to bring in some of the participants and ask you if you are comfortable with whatever we have had so far, and so that I get a feel of where you are. Akshant Sharma, I'm unmuting you, and I would like to hear from you if you are so far with me and you understand the pathophysiology that we discussed. Akshant. Probably Akshant doesn't want to respond or is unable to respond. I will unmute Ayush Arya. Ayush, if you can tell us if you are still with us and if you are clear on the pathophysiology.
Yes, sir, I'm following.
So can you repeat the pathophysiology and you can tell me what happens and how the pathology develops?
Sir, anti-phospholipid antibody syndrome, we have, sir, antibodies against the plasma proteins that are associated with the phospholipid, and then when there's antibody response, there is endothelial dysfunction, and it will lead to thrombosis, and there will be clinical features according to the thrombosis. And in clinical features, sir, there can be, sir, from asymptomatic and thrombosis or stroke can occur. Stroke and ischemic attacks can occur, and in pregnancy it can lead to pregnancy loss after 10 weeks.
Perfect. Thank you. Thank you, Ayush. This was Ayush? Yes. So this was the pathogenesis. You have the beta cells producing the antiphospholipid antibodies, which bind to the beta-2-GP1 proteins, which open up, bind to the endothelial cells, cause activation of inflammatory cells, promote coagulation, leads to pregnancy complications, thrombosis, inflammation, and vasculopathy. Not a very difficult thing to draw, and it will be helpful if you draw such a diagram in your exam, because then it will be easy to give marks. So most of this antiphospholipid antibody syndrome you would not be getting as a clinical case in your exam for presentation, but you will definitely get this as a short note. So most of the time you will get a short note, and while correcting the short note, if I see such a figure which is already there, then it gives me a greater in-depth view that the student has understood, and is easier for me to give you more marks if this kind of a figure is there, which depicts the pathophysiology, the clinical symptoms we discussed, and the spectrum. So here we are, and we were talking about the spectrum of clinical features. And another category which I would like to highlight at this point is a special situation when you have a SLE, or the systemic lupus erythematosus, and you have an APLA positivity. So you have antiphospholipid antibodies positive in a patient with SLE. And in these cases, there will be more chances of complications if APLA antibodies are present. So those patients of SLE who have APLA antibodies present have more chances of complication, whereas those patients with SLE who do not have the APLA antibodies present would have a fewer chance or a lower chance of developing complications such as vascular disease, pregnancy losses, thrombosis, livedo reticularis, thrombocytopenia, or even hemolytic anemia. So going further from here, the clinical features, this is more of a repetition in this and future slides, but more or less there is a direct or indirect expression of venous thrombosis, arterial thrombosis, and pregnancy morbidity. So practically, the clinical features revolve between these three features. There is venous thrombosis, there is arterial thrombosis, and there is pregnancy morbidity. So venous thrombosis presents, like we said, as a deep vein thrombosis or pulmonary emboli. In addition, there could be intracranial hemorrhages, there could be cortical sinus venous thrombosis, there could be there would be the retinal vein thrombosis. Let me engage my pen again if I can. Yes. And so you have intracranial hemorrhages in addition to retinal vein thrombosis and Budd-Chiari syndromes. In arterial thrombosis, we have migraine, cognitive dysfunction, TIAs, strokes, ischemic ulcers, digital gangrene, avascular necrosis of bone. But more or less, if you do remember only TIA and stroke, that would be sufficient if you write in your answer that arterial thrombosis is mostly represented by TIA or stroke patients. The pregnancy morbidity is usually after 10 weeks of gestation. So most pregnancy losses in APLA are after 10 weeks of gestation. However, early losses may occur. And in these cases, we do give low dose aspirin, heparin to prevent future losses. So this brings us to an important question. When would you suspect antiphospholipid antibody syndrome? So generally, there are about 4 or 5 conditions when you should really think of APLA, because you can't go about testing APLA antibodies in most of the patients or all the patients that you see. So if you find that there is thrombosis occurring at young age, so you find that there is a young patient who presents with a venous or an arterial thrombosis in terms of a DVT or in terms of a stroke, then you do start thinking of APLA. If you find that there is a patient who comes with recurrent thrombosis, that means there was one episode of DVT earlier, and now there is another episode of DVT, or there are multiple episodes of thrombosis occurring at the same location or at different locations, then you do start thinking of APLA and get their tests. If there are late pregnancy losses, so what was late pregnancy losses? We said more than 10 weeks of gestation. If you get pregnancy losses then you start thinking of APLA. Or if you have early or severe preeclampsia, then again you start thinking of APLA. And in cases of HELP syndrome also, you start thinking of APLA. So I'm again going to unmute Anusmita Sharma. So Anusmita, you are going to tell me what is HELP syndrome. Anusmita? Yes, I can't unmute her for some reason, but let's try Bhupinder. Bhupinder, if you are there, your mic is now unmuted, and I would like you to tell me what is a HELP syndrome. So it seems Bhupinder doesn't want to answer. Let's try Divya Mathur. Divya, if you are still around and if you are with us, could you please enlighten us about what is HELP syndrome? And if Divya doesn't answer, next it goes to Gargi Sharma, roll number 44, as she has identified herself. Gargi, are you
Hello.
around? Yes, Divya.
So HELP syndrome is the most common reason in pregnancy for APLA syndrome, and it is due to mainly hypertension presentation in pregnancy. The liver enzymes are also elevated, and uh, recurrent pregnancy losses occur in HELP syndrome.
So can you elaborate what is the acronym HELP standing for? HELLP, what is HELP?
Sir, it is hemolysis, elevated liver enzymes, and low platelet count.
Cool, very good. Thank you. Thank you, Divya. So yes, HELP syndrome, as you rightly described it, is hemolysis, elevated liver enzymes, and low platelets. So there are some associated features which, if present with all these 5 that we have listed, if the patient has thrombosis, recurrent thrombosis at an early age, late pregnancy losses, early or severe preeclampsia, and HELP syndrome, and in addition, she also has one of these features, such as livedo reticularis, mild thrombocytopenia, and unexplained prolonged APTT, then we start thinking more strongly of the APLA syndrome. So Gargi, your mic is unmuted. Gargi, could you tell us what is livedo reticularis?
So, so basically, it is due to arterial thrombosis. No, sir, it is due to venous thrombosis when the small veins, which are on the mainly, um, so means when the small veins are thrombosed, then it leads to a pattern of some wavy pattern of the veins, small veins. Then
Cool. So absolutely correct. So when you find that there is a skin pattern of the veins which is seen, and you find that there is an intricate networking pattern which becomes visible on the skin, as you can see on your screens now, is what we called a livedo reticularis. So when we see livedo reticularis or a mild thrombocytopenia or an unexplained prolonged APTT, in addition to one of these 5 features, then we do say and start suspecting the APLA and would go in for an antibody testing further. Now, there are a few diagnostic criteria which are used in identifying the APLA syndrome. And one such criteria is the Sapporo classification criteria. Now, there is a difference between a diagnostic criteria and a classification criteria. But let's suffice here to say that Sapporo classification criteria is commonly used for diagnosis of APLA syndrome, although they are revising it now, but currently this is the classification that is used. So clinical criteria includes a vascular thrombosis, could be arterial or could be venous. It includes pregnancy morbidity. So there should be one of these which should be present, either a vascular thrombosis or a pregnancy morbidity. In addition to one laboratory criteria, which could be either of these 3, which is a persistent APL or anti phospholipid antibody, which is measured on 2 occasions, at least 12 weeks apart. So all these 3 have got this criteria that they should be 12 weeks apart, on 2 occasions. So it could be anti-phospholipid antibody positive, anti-cardiolipin antibody positive, or anti-beta-2 GP1 antibody present. So any of these 3 antibodies present 12 weeks apart on 2 occasions in a patient who presents with vascular thrombosis, maybe arterial or maybe venous. So vascular thrombosis, which is, it's difficult to write with this pen, but let's try. So it could be arterial, or it could be venous. So there is a clinical criteria which has to suffice one of these and one of these, which will give us a definitive diagnosis or classification of antiphospholipid antibody syndrome. This is another table which includes the other manifestations of antiphospholipid antibody syndrome that are not included in the revised Sapporo classification criteria, which we saw in the earlier slide. So this was the Sapporo classification criteria, and these includes those manifestations which are not included in the Sapporo classification. These could be hematologic manifestations such as thrombocytopenia. These could be hemolytic anemia. These could be the renal complications such as acute thrombotic microangiopathy. And there could be chronic vaso-occlusive lesions. There could be cardiac features such as vegetations which might be present. There could be dermatologic features such as livedo reticularis. There could be livedoid vasculopathy, and there could be cognitive dysfunction. Now, cognitive dysfunction is often seen as one of the presentations in the absence of stroke. So there should be no stroke, and there is cognitive dysfunction. These are the other classification features which could be seen in cases of antiphospholipid antibody syndromes, which are not included in the Sapporo classification. Before we go on to the management, let's again take a break. And Kaushiki, your mic is unmuted. So could you tell us a little bit about what you were able to gather from the previous discussion that we had on APLA syndrome, or the clinical features of APLA syndrome and the diagnostic criteria? Kaushiki.
So there is criteria for diagnosis. According to that, based on clinical manifestations of thrombosis, arterial or venous, we can diagnose it. And apart from that, presence of antibodies, anti-cardiolipin antibodies, and beta-2 GP1 antibodies on 2 occasions, 12 weeks apart, made.
Awesome. Thank you, Kaushiki. Lakshay, are you with us? Could you tell us again? Yes. Hi, Lakshay.
Yes, sir. Sir, you told about us about the clinical features. The clinical features mainly presents with the thrombosis, various thrombosis, and the pregnancy morbidity. The clinical classification is the Sapporo classification, which consists of clinical features and the laboratory features. Clinical features are the two that I told you, that the pregnancy morbidity and the vascular thrombosis. And the laboratory features are the 3 antibodies: the anti-cardiolipin antibody, anti-beta-2 GP1 antibodies, and anti-phospholipid antibodies, which are done on 2 occasions, 12 weeks apart. And for the diagnosis, we need 1 clinical feature and 1 laboratory feature.
Cool. Thank you so much, Lakshay. Naman, are you also with us? Naman, your microphone is also unmuted and you can speak. Naman Sharma. So only his computer or his phone is with us. Maybe Naman is not around. But so far, so good. Thank you. Let's go ahead. Let's talk more about management. So management is basically either primary prophylaxis or secondary prophylaxis. So primary prophylaxis is before the first episode of thrombosis happens, and that is when the risk factors are there. but the thrombosis has not yet happened. So the status of primary prophylaxis is still controversial. So before the first event occurs, we do not give any prophylaxis because the chances of developing a thrombosis, even in patients who have antiphospholipid antibodies circulating in their blood, is relatively low and is as low as 1% in most individuals. So that is less than 1%. So we don't give primary prophylaxis to these individuals. However, if the patient has SLE, then we do consider giving prophylaxis to these individuals because here the chances of complications are much higher. So primary prophylaxis is not given in patients with APLA unless they are also associated with SLE when we do consider it. Otherwise, it remains controversial and is not given. Secondary prophylaxis is done when there is one episode of thrombosis which has already happened, and then there are chances that the person may develop another episode of thrombosis, whether venous or arterial, and in these cases we do offer them secondary prophylaxis. If the first episode was a venous thrombosis, then we keep the INR between 2 and 3. INR is internationalized normal ratio, and we would like to keep it between 2 to 3 for prothrombin time. We check the prothrombin time and we check the INR, and if the INR is between 2 or 3, we maintain it between 2 or 3. We give initially low molecular weight heparin and then continue with the long-term anticoagulants such as warfarin, and we titrate the warfarin in such a manner that the INR is between 2 and 3, as we said in the previous line. So if there is an arterial thrombosis, then it's usually, if it's a low risk patient, let's say it's a patient who's a 70-year-old patient, has first developed an arterial cerebrovascular accident and has presented with stroke, then we feel that prophylaxis with aspirin is enough, and we do not give anything further if they even test for angiopolypin antibodies. However, if the risk is higher and it's a younger person who's presented with stroke and the antiphospholipid antibodies are positive, in those cases, or lupus anticoagulant is positive, then we do consider warfarin in these patients. And again, we would like to maintain the dose of warfarin in such a manner that INR is maintained between 2 to 3. So that is the key in the management for prophylaxis. For treatment, usually if it's incidentally detected and there are no symptoms, but if they also have the antibodies or in addition to SLE, then we do give them treatment with aspirin, 80 milligrams once a day. After first episode of thrombosis, like we saw in the previous slide, we do consider for secondary prophylaxis warfarin and aspirin, depending upon what is the nature of the first episode. And in cases of pregnancy morbidity and fetal loss, we would like to keep them on heparin and aspirin. And we also give IVIG 400 milligrams. IVIG is intravenous immunoglobulin 400 milligrams per kg once a day for 5 days in order that they are able to maintain their pregnancy and complete their pregnancy to prevent any further chances of fetal loss. So pregnancy-induced or pregnancy-related APLA, we treat with heparin and aspirin and with IVIG. So please remember that the management is very different in cases of pregnancy-induced morbidity and fetal losses, which need to be handled more carefully and more sensitively. For catastrophic APLA, so what is catastrophic APLA? We saw in a previous slide. It's catastrophe means there is grave danger or there is catastrophe, there is life-threatening illness in which there is thrombosis of multiple organ systems at the same time, leading to a situation where there may be a severity enough to complicate life, and then we treat with anticoagulants. We also give steroids and plasma exchange in addition to immunoglobulins, the intravenous immunoglobulins that we saw in the previous slide. So that in a nutshell mostly completes the treatment of APLA. Here I have also included one table which summarizes the therapy options that are available to us for the management of APLA and the different or the latest drugs which are available to us. And with this, I would close this class, but before that, let's take some comments from Sonal. Could you give us some insights into management or the presentations of APLA in cardiovascular diseases? So for those who joined late, let me also introduce to you Sonal Pruthi, who is one of our students from the 2008 batch from UCMS, and she's currently pursuing a fellowship in the United States of America. She's pursuing a fellowship in interventional cardiology, and it's 3 o'clock in the morning, and Sonal agreed to join this class so that she could interact with you. So Sonal, all yours.
Yeah, no, the only time I see them is obviously younger people presenting with MIs. Like they come in and they usually present with big MIs, like ST elevation MIs on EKGs. That's usually because they have a thrombus. Like we said, we are saying all the manifestation is because of thrombosis. So a lot of times they have thrombus and it's both arterial and venous. So they either present with a ST elevation MI on your ECG. And when you go in and take a look, all you find in the arteries is a clot, rather than what you would see in some older people, where you would actually see that the lipid or the cholesterol-rich plaque has ruptured, which is typically the case, unlike these people who are younger and have a clot. And the second thing we see them is for people with pulmonary embolisms. Usually, if they come in with big pulmonary embolisms, they have problems with the right side of the heart, and they are in heart failure or sometimes even in cardiac arrest, because they developed a pulmonary embolism and their oxygen saturations dropped, and eventually they had a cardiac arrest. And then the third thing we see them is when we work up people for stroke. Then you see, when you're trying to work up younger people with stroke, in older population, as we were saying, what you have is mostly just what you would expect is over time there is lipid, cholesterol, calcium in the arteries. But in younger people, if you have stroke, you look for other causes. So you look for anything that can lead to thrombosis, and one of them is APLA. Especially in people with SLE, you have, we all read about Liebman-Sachs endocarditis. So they have vegetations or thickening on the valves, which can then break off and then lead to all these strokes. So yeah, the management is anticoagulation. The only approved anticoagulant is warfarin. Now warfarin, it is easier said than done to keep people on warfarin, because one, you have to tightly regulate INR, and it is very variable. Like if you go and it's all vitamin K dependent. So if you tell your patient to take warfarin, one, the dose keeps varying, and two, let's say he goes in and eats a little extra salad or more greens, then their INR goes down because they have more vitamin K. So you need to monitor these people continuously. And two, with APLA, it also interferes with your testing for INR. So even though your INR test might come out to be, within the range of 2 to 3, like the INR might be 2.5 on your testing, but it just might be a test interference because of antibodies rather than their actual INR being 2.5. So in those patients, if they're already on warfarin and if they're still having more thrombosis, one, you have to consider that they did not have enough. They did not take their medicine, or they took extra things here and there which caused a change in the INR when you were not measuring it. Or two, you just need to change their INR goal and add aspirin on top of warfarin. So if they have clots on top of being on warfarin, then you can add aspirin. The last thing I have is there are newer anticoagulants which do not require monitoring, like Coumadin or warfarin. In the sense that they do not interact with your green leafy vegetables. You don't have to get weekly INR checks for these people. But none of them have been approved yet. There are trials underway for two of the newer anticoagulants that we use now. One is rivaroxaban. I'm sure you all must have read about rivaroxaban. So rivaroxaban and apixaban, those are the two anticoagulants we've started to use if people were not able to maintain their INR on Coumadin, because it's much easier said than done to keep people on Coumadin or warfarin. Yeah, that's all I have.
Thank you, Sonal. So if there are any questions, you could raise your hand and I would unmute you if you would like to ask something to me or to Sonal. I don't see any hands yet, but if there are any hands, we could have your mics unmuted and you could speak. In the meantime, if you're thinking of your questions, I would like to invite Sonika. Your mic is unmuted. Sonika, if you are there, could you just tell us quickly or briefly what you picked up on, what you remember from the last 30 minutes of discussion? Sonika. So probably Sonika is also not here. We're only looking at her computer. Yutika, are you around? Yutika, if you would like to tell us what you gathered from this. Yutika Khanna. Yes, go ahead, Yutika. Nope. Swarnima, are you around? Swarnima, your mic is unmuted, and if you would like to speak, then you could go ahead and talk. Nope. So do we have Muskan or Mohit Soni? Cool, fair enough. I'm unmuting all of you, so if anyone wants to speak, please go ahead. You are all unmuted, so if you would like to go ahead and talk, there is anything that you want to say. So we see one hand. Let's see. Your mic is unmuted, Abhik Basure. Go ahead and talk.
Sir, what is the trigger for the antibody production, and is there any genetic susceptibility to it?
So yes, it's an auto antibody which is produced, and the trigger to the antibodies production is not very clearly identified as so far, and we really don't know what triggers it. But mostly the association with autoimmune diseases such as SLE, systemic lupus erythematosus, leads us to believe that there is definitely a genetic involvement, and there could be a link. But to clearly say that there is one specific trigger, no, we don't know. Although we say that risk factors such as smoking and healthy lifestyle, I mean, you should be adopting healthy lifestyle and avoid smoking to reduce the risk for thrombosis, yes, but what triggers in particular antibody production, no, that's not clear.
Thank you, sir.
Thank you, Abhik. Fair enough. So thank you for joining this class, and I hope it goes on well for you. And I would also like to add, for those who are listening, that Sonal has volunteered to engage with you in classes if you would like to have some sessions on ECG analysis and identifying or reading ECGs. And we could organize such sessions depending upon how much interest we are able to generate within you. So in case any one of you is interested in those classes, feel free to write back to me or let me know, and we would engage Sonal in more such sessions where we would be discussing ECGs online. Thank you. Thank you, everyone. Bye-bye. Have a good day.